Welcome to Med Decode. Today we're diving deep into a topic that frankly gave me significant pause when I saw the source material. We're talking about pediatric hypertension.
High blood pressure in children.
Exactly. And this isn't some, rare medical anomaly. It's actually rapidly escalating into a global health crisis.
Oh, it really is.
And if you're a parent or guardian, especially in that sort of 40 to 50 age bracket, this is essential stuff to know. These are the risks facing the young people in your life. Well, right now.
That's absolutely right. The data we're looking at today it's stunning. This comes from a massive global meta-analysis covering over 3.6 million children and adolescents all over the world.
3.6 million, wow.
And the trend it reveals is that childhood hypertension, it's not just a passing phase. It's a powerful predictor of pretty severe adult heart issues and down the line, organ damage.
So our mission today is to cut through this colossal stack of research and pull out the most critical insights for you. And right out of the gate, we hit this massive contradiction that we just have to resolve. Here's the first mystery we have to unpack. Why are there two radically different prevalence numbers for this floating around? One source says the prevalence is 11.85%, but another says it's only 3.89%.
That's a huge difference.
It's almost a threefold difference.
Yeah.
Okay, let's unpack this. Which number is the real one? Which one actually reflects the true crisis?
Well, this huge discrepancy is actually one of the most critical and I think valuable findings of the research. Our goal here is to help you distinguish between the true chronic disease burden that needs action and what's, essentially statistical noise from screening procedures.
Okay, let's jump right into that diagnostic dilemma. Why does the prevalence figure drop so dramatically from nearly 12% all the way down to less than 4%?
It all comes down to how the diagnosis is made. These two numbers, they basically represent two totally distinct standards for measurement.
So let's start with the high one. What does that 11.85% actually represent?
Okay, so the 11.85%, that refers to what we call occasional hypertension. This big number is based on a single screening visit.
Just one visit.
Just one. Many studies, for convenience or cost, they'll measure blood pressure just once during a routine checkup. If the reading is high, boom, it gets tallied. But this method often leads to a massive overestimation.
That sounds a lot like what we call white coat hypertension, right? The kid might be stressed or nervous about being in a clinic, or maybe they were just running around beforehand.
Exactly. It's situational.
So it's not a chronic illness.
Precisely. A single reading can capture stress, tension, momentary fluctuations. And the research confirms that this single visit screening severely overestimates the true prevalence. Like you said, it's nearly 3 times higher than the sustained rate.
Okay, so the 3.89% figure, the lower, but still pretty serious number.
Yeah.
That must be the true measure of sustained hypertension, the chronic condition we should actually be worried about.
Yes. That 3.89%, that reflects the actual global chronic burden that requires medical intervention. This figure, it sticks to these really rigorous international standards, specifically the 2017 American Academy of Pediatrics guidelines.
And what do those guidelines say?
To meet the stricter definition, the child has to register high blood pressure readings on at least 3 separate clinic visits.
3 separate visits. That's the crucial difference.
It's the whole ballgame. And what's fascinating here is that the study doesn't just confirm this clinical need, it puts a hard number on the level of misjudgment that happens when we skip the follow-up.
You mean the 3 times higher part?
Mm-hmm. The prevalence of occasional hypertension is nearly 3 times that of sustained hypertension. It sends a clear message to clinicians and parents. Never, ever rely on a single elevated reading alone. You have to track it.
So, to put it into action, if your child's blood pressure is high on a school screening, don't panic. That's potentially in that 11.85% bucket.
Exactly.
But if the doctor asks you to come back 2 more times, and those readings are also high, then you're moving into that serious 3.89% territory, and that demands immediate attention.
That's the key takeaway.
Okay. Now that we know how to measure this crisis accurately, let's look at what's driving it. What's behind this climbing 3.89% rate? The data on this was, absolutely unequivocal.
It was crystal clear.
Weight is the #1 culprit driving children's high blood pressure.
This conclusion is rock solid. The data provides this direct quantitative evidence of a really powerful and steady link between being overweight or obese and having sustained pediatric hypertension.
Let's look at the numbers, because the contrast is staggering. Using that strict sustained hypertension standard, kids with a normal weight have a prevalence of just 2.57%.
Correct, but watch what happens when we just move up one category. For children who are classified as overweight, that prevalence immediately more than doubles. It jumps to 6.79%.
Wow, just for being overweight, not even obese. And what about that most concerning category, the kids who are obese?
For obese children, the sustained hypertension prevalence just skyrockets to 16.35%.
16.35%. That means an obese child is, what, roughly 6 times more likely to have sustained hypertension than a normal weight child.
That's the math. It's a dramatic level of risk amplification.
And some parents might be thinking, my child is just a little heavy, they're not clinically obese yet, should I be concerned?
Absolutely. Even just falling into that overweight category, that middle ground, more than doubles the risk to 6.79%. And beyond that, we need to focus on a specific type of weight gain.
What's that?
Central obesity. Basically, excess abdominal fat.
The belly fat that we usually associate with, like adult metabolic syndrome.
Exactly the same thing. And in kids with central obesity, they show a sustained BP prevalence of 9.45%.
Okay, 9.45%. How does that compare?
It's 3 times higher than the rate for children without central obesity, which is only 3.00%. It really highlights that where the fat is deposited, especially around the abdomen, has a very direct, very negative impact on cardiovascular health, even in youth.
So, in short, this research is handing us a very, very strong signal for public health policy.
Without a doubt. If we connect this to the bigger picture, the research clearly mandates that all future public health efforts must laser focus on weight management and promoting healthy lifestyles. This is, hands down, the most powerful lever we have for prevention.
Focusing on this massive culprit obesity really brings us to the gravity of the whole situation. Does childhood high blood pressure just resolve itself? What happens if we ignore it? The sources describe it as a ticking time bomb.
That's a good way to put it. It is not a transient condition that kids simply outgrow. The research clearly indicates that a child's blood pressure percentile tends to track directly into adulthood.
So it follows them.
It follows them. This established trajectory of high pressure, it just accelerates the onset of serious adult cardiovascular disease.
So if your blood pressure is high as a kid, you're highly likely to be an adult with hypertension later on.
That's one consequence, yes. They face a greatly increased risk of developing adult hypertension. But what I find far more alarming is the evidence of early organ damage. The sources call them subclinical symptoms.
Subclinical, meaning the damage has already started, but there are no obvious outward symptoms yet.
Precisely. This includes early signs like left ventricular hypertrophy.
Itches.
It's a thickening of the heart wall. And also increased carotid intima media thickness. These are classic markers of stress and damage to the heart and the blood vessels, all caused by that chronic high pressure.
These sound like issues we worry about after decades of wear and tear, in our 40s or 50s.
But sustained childhood hypertension sets this process in motion prematurely. And in the long run, this significantly elevates the risk of severe cardiovascular events. We're talking stroke and myocardial infarction, a heart attack later in life. Childhood high BP is a powerful early predictor.
Okay, so if this is a ticking time bomb, is the countdown speeding up or is it slowing down? What does the global trend tell us?
Unfortunately, the news isn't great. The global trend shows a significant and, frankly, accelerating upward trajectory. This crisis is getting worse, and it's getting worse fast.
Give me the numbers on that acceleration.
Okay, so if we analyze the most accurate measure, that sustained hypertension number, we see a statistically significant increase just between 2006 and 2021. The annual percent change, or ATC, over that period was a staggering 7.20%.
A 7.22% annual growth rate.
Yeah.
That is an alarming pace. And here's where it gets really interesting. That rapid growth is almost certainly driven by the global parallel rise in childhood obesity.
It is the primary engine, yes.
Yeah.
But beyond weight, the study did identify 2 other crucial, non-modifiable risk factors that parents should be aware of.
Okay, what are they?
The first one is age, or more specifically, adolescence. Teenagers, defined here as 13 years or older, have significantly higher rates of sustained high blood pressure than younger kids.
By how much?
The prevalence for that 13 and up group is 13.55%. Compare that to only 4.01% for those under 13.
That's a huge jump.
It is. This spike is likely related to the rapid increases in height and body mass that happen during puberty and those big growth spurts.
So parents need to pay extra attention during those years.
Yeah.
Okay. And the second critical risk factor?
The second is a family history of hypertension. If a child has a family history, their sustained BP prevalence is higher at 5.05%, which is significantly above the 3.07% rate we see in children without that history.
Which strongly suggests a genetic component.
A crucial genetic component is at play in early onset hypertension, yes.
So if you, the listener, have high blood pressure yourself, you need to be that much more proactive about screening and tracking your own child's readings. We also saw some geographic variation in the data, didn't we?
We did. The Western Pacific region, which includes East Asia, showed the highest sustained prevalence at 5.33%, while the Americas were the lowest at 2.53%. It just confirms the global scope of the challenge, but also shows the burden isn't evenly distributed.
So we've covered the diagnostic myths, the obesity driver, the long-term dangers, and this alarming global growth trend. Now, for the most important part. So what does this all mean for you? What can people do?
We can break the action plan down into two main areas. There's diagnostic integrity, and then there's primary prevention.
Okay, diagnostic integrity. That means sticking to that strict standard we talked about.
That's right. Action point 1, standardized screening. All parents and clinicians really must insist on and follow the AP guidelines for multiple measurements. We have to make sure we're capturing that chronic 3.89% rate and not overreacting to the occasional 11.85% spike.
Makes sense. And primary prevention means going after our biggest enemy, obesity.
Action point 2, primary prevention. Given that weight is the absolute biggest driver here, all public health and parental efforts must focus on it. This means targeted interventions to promote healthy lifestyles.
That's like
Encouraging active play, limiting screen time, and prioritizing healthy, low-sodium diets, all to manage and prevent childhood overweight and obesity.
Now, this massive study also raised a key challenge for the future of medicine, which I think we need to touch on.
It did, and it's an important one. The researchers noted that many non-U.S. studies rely on U.S. diagnostic standards to assess children in their own countries. And this raises an important question about whether that's appropriate.
So we can't just apply American standards globally and expect them to fit.
Exactly. Different ethnicities and populations worldwide have varied body types, different growth curves. The study urgently calls for establishing truly international reference values for pediatric and adolescent blood pressure.
So they would be tailored to different populations.
Exactly. This would allow for much more accurate global comparison and ensure that kids in different regions get diagnostic standards that are truly tailored to them. That really is the next frontier of this research.
This deep dive has delivered some major knowledge shocks. I feel like we learned 3 vital things today. First, diagnosis requires a triple check. Never, ever rely on a single reading.
Absolutely critical.
Second, obesity multiplies a child's risk of sustained hypertension by 6 times. It is the primary enemy. And third, this entire crisis is accelerating at an annual rate of 7.20%.
These are numbers we absolutely cannot afford to ignore.
Absolutely. So if weight management is the single most effective intervention we have, let me leave you with one final thought to mull over. When the dominant cultural trends, from high-sodium processed foods to passive screen time habits, are all pushing children toward obesity, what single concrete step can you take this week to actively lower the lifetime cardiovascular risk for the young people in your life?
Being informed, just like you are by listening to this, is the crucial first step toward any lasting change.
Thank you for diving deep into the sources with us. We'll catch you next time.
And that's a wrap on this episode of MedDecode. I really appreciate you joining me today. If something we talked about sparked your interest, or if there's a medical term that's been bugging you, let me know in the comments. And if you enjoyed this, be a pal and share it with a friend. We'll catch you on the next one.